And then if anyone joins, they can join.
Yeah.
Hi. So I don't know if everyone knows me, but I'm Mel, one of the head and neck specialist nurses here at MRI. And I'm Chloe.
I'm Chloe, I'm the only service.
So Eric has asked us to come in today just to go through, it's basically just a general chit chat just about our job roles, So it's just a little bit about our job roles, what we do, and then we're going to go into a few of the things that we've implemented recently that we're seeing changes in the service. So my role is head and neck cancer, part of Macmillan. We are adopted by Macmillan with me and Anna. And then there is Chloe, who is the auxiliary nurse, sees a lot of our cancer patients, but is not Macmillan badged or adopted. So a few of the things that we'll discuss, it's knowing who to contact and who does what, it does cross-link, don't it, all the time. So I see all cancer patients. Basically, I cover ENT, and then Anna covers max facts, but we cover each other as well when off. Always there for breaking bad news. And I think whenever anyone is given a diagnosis, there should always be a CNS there. If I'm off, Anna will always be here, so there should always be me or Anna at a diagnosis. And that's where it's on the ward, in clinic, on a Tuesday at 3 o'clock, I'm still here. So if anyone ever needs me, do you all know our bleep number? So a lot of people get confused that they'll say we can't get in touch with you for Sarah. We don't have the Sarah. So we have the bleep. So if anyone ever needs a diagnosis, don't WhatsApp me. They don't always have signal on the ward. You can phone the ward, but just bleep. And my bleep number is 8561. Absolutely. But also our contact details are all in clinic. They're all on the ward, so everyone can always get in touch with us. The other thing that, because a lot of people, you know who we are, and a lot of the ENT team know who we are, and we know our role, we know it's oncology. But in the background of doing diagnosis and things, we have a thing called, have you ever heard of Macmillan Personalised Cancer Care?
We've heard about it.
You've heard about it, yeah. So basically, years and years ago, they used to have the Macmillan brought out the personalised cancer pathway. They've changed it now to care plans, but it's about getting a cancer diagnosis and being supported right from day dot about your worries, concerns, all the way through treatment. And it's divided into like 4 sections. So one of them is the holistic needs assessments. I don't know if you've heard of them before, but at each diagnosis, every patient will get offered a holistic needs assessment. And the idea of them is, when anyone's had a cancer diagnosis within head and neck, or any cancer in any speciality, they'll meet the CNS and then we'll speak about any worries or concerns. So rather than give them, like what happened many years ago, you'd give them a leaflet off the bookshelf of every concern that they could have and they'd go away. Well, now we try to identify concerns and worries at that stage. So at a diagnosis stage, during treatment, they always get on at discharge, and then I'll go on to end of treatment. So they get a checklist and they'll tell us what their concerns are, whether it's finances, who's going to look after my cat, who's going to look after my dog. And we always do that a couple of days after a diagnosis. So we phone them up, or Rachel, and Rachel's our cancer care coordinator. So they'll phone them up and they'll either arrange a face-to-face meet or we'll do it over the telephone. Some patients can have no concerns, it's like, no, just want to crack on, and we'll document that, and it always has to be documented because they can get checked and all the data is collected. Some people have every concern, so then you'll identify which are the top 5 at that point. If it's financial, we can do Macmillan welfare grants. So if you were speaking to a patient and it was during treatment and they said, I'm really struggling, I'm not going to be getting paid, I'm going on to half pay in 6 months, then let me know, because then I can go speak to the patients support them in their worries and concerns, but also do welfare grant checks, and I can refer you to the welfare rights, meaning that everyone can be entitled to something from Macmillan. And also, when we do the referral through to our welfare grant checkers, called Peter Hand, that's all I know, advisors, they can then go into PIP claims, disabled badges, disability allowance, so it can be used wider. So if anybody ever gives you any words of concern, refer them to us and we can go and just delve into it a little bit more. We've had people concerned about the cat, one recently, so we have to get in touch with charities. We do lots of phone calls in the background. People worried about children, who's a look after because they're a single mother. So it can be anything. And then obviously, well, you know, don't you? It can be anything from how I'm going to smile, how I'm going to reach something at the top shelf. So anything like that. So we always do them at diagnosis. They also get one on discharge as well. So in the background, we are constantly doing all this in the office and making phone calls. Once we've done the holistic needs assessments, then we have, which I've only just started bringing in now, so you need to be aware of the treatment summaries. So I don't know if you've ever seen a treatment summary from different hospitals. Christie's do them, and it's what it says on the tin. It's a summary of the treatment. So anybody at the moment who's coming to our clinics, who's laryngectomy, we've started it. I've only done 2 at the moment, and what it basically means is from surgery all the way through to the MDT, where we've discussed the MDT, we've got the results, and they're either going for radiotherapy or we're observing them. That's the end of their treatment. If they're going off to Christie for radiotherapy, they do their own treatment summary, and that gets posted to me, so then I can have a copy of that. So what we do is they come in, they have the surgery. If there's any complications, so with laryngectomies, if there's any issues with valves or there's any fistulas or wound breakdown, that will get put into their treatment summary, and it's written to the patient, not to the GP. So it's written using patient language as well. We send a copy to the patient, the GP gets a copy, and he also sends it to the specialist nurse because we cover Bolton, Wigan, Tameside. So then everybody is aware of the whole treatment that they've had while in hospital. So we do it with laryngectomies.
Can I ask a question?
Yeah.
Is that a generic?
Yes.
Or if it's patient specific, do patient summaries that you provide with?
Yeah. So at the moment we're doing laryngectomies only because it is written.
Oh yeah, it's a generic. Yeah.
Yeah. So but anyway, you can edit and delete it. I'll show you. And it's used trust-wide for the MFT as well. So within Shaw, North, and us. The neck dissection, that again is neck dissection and thyroid. And then we've got a head and neck one, which the head and neck one is like the max facts as well. So we're trying to create probably a different terminology on trying to what we've done for ENT for max facts, because it's so intense and the surgeons are all completely different. You have to be able to edit it so it's unique for that patient.
Yeah.
So that's why when you do your treatments, if you have a laryngectomy, I tend to do it, and I'll do the inputting as the patient's an inpatient. So if we had a laryngectomy coming in on Monday, I'll start that. So you can edit and delete as you go. So you can. So say if they do get a fistula from a swallow, you can put that in, and you can put the dates in. So you can say you had a fistula test, you had a swallow test on the 29th of March. However, you had a leak, so we have to keep your nil by mouth for so many days, and we repeated it on. You can type that all in or copy and paste it over.
So are you updating that as they are?
Yeah.
Okay.
Yeah.
That'd be amazing for the discharge summaries as well. We can access that.
Yeah, I'll show you how it literally is.
Is it on high?
Yeah. If you could share it, I could show you how to get it, but I can't.
Share Hive.
Yeah.
Copy Hive, yeah.
Because I can show you one.
Which version?
So at the moment I've done laryngectomies.
Did you share it in there? Can I share in the Teams as well with patients?
No.
What I can do is I'll create a blank one. I have got some blank ones. They're on my Word. I've got them on my desktop.
That's okay, no worries.
And basically, yeah, you go in and just put all your information in there. We've done laryngectomy. I am going to start bringing in neck dissections. We're having to just bring them in gradually, because what I want to happen is us all to have involvement in them. So as I do it, I can share it. So if you're the doctor or consultant, when I'm typing, I have to send it to the consultant to check it. And then when they come to the end of the treatment and to the MDT, I'll print a copy off, and then after you've told them if they're ready for therapy or not, that's where I'll say, right, I'm just going to stay and go through what signs, symptoms to look out for, you know, when to contact us, worries, and it goes through all that. So they're really good. So what I can do is send you a copy of the patient blank one of the laryngectomy neck dissection, and then you can share it to people so they can just have a look at it.
Yep.
So that's up and coming. That's something that's happening. I always have to be consultant sign off. So I always send it to the consultant. If you've been in surgery with them, I'll also send it to you. So if there's anything that you need to add, you can edit and add it in. That's absolutely fine. And I would never ever share it with a patient until a consultant is okayed it. And then after that, you have the cancer care reviews, which that's a 6-month follow-up. So this is why it's really important that the GP gets these treatment summaries, because the GP 6 months should be doing a cancer care review at the GP. So after treatment summaries, once they've received that, they should be following up with patients after 6 months. It'll be really good for thyroid patients as well, or if in the treatment summaries we say to patients, if you're feeling really lethargic, tired, go to your GP, get your bloods checked, thyroids, get your thyroids checked. So it'd be really good for that. And then the health and wellbeing event. And that's a part of the personalised cancer care, making sure that we're supporting all the patients after diagnosis. So these are the things that we're doing in the background, as well as being on the ward, seeing patients, supporting the patient, supporting the staff, doing diagnosis. In the background, then we're having to do these as well. The health and wellbeing event, Rachel, our cancer care coordinator, is amazing, and she started organising it probably 6 months ago, inviting, probably 12 months ago. She phones all the patients, invites them, and then we re-phone them and just say, are you still confirming? Then we send letters out, and we treat it like an appointment for patients. You've got this appointment to come to attend. And that's about networking with other patients, but also getting support about living with and beyond cancer. That you're not just end of treatment, done, and then we'll see you in clinic every so often. And you feel, some patients have said a little bit abandoned, not knowing who to turn to. So it's really good for that. You're all welcome if you wanted to come and just see what it's about. It's on Monday the 31st of July from 12 o'clock, and it's here in seminar room 1 and 2. So it is really, really good. We have speakers, but then how we've kind of wanted it to look, we don't want it to be really formal. It's for patients. It's not a lecture. We don't want it to just be spoken to. So we've said we'll have an hour of speaks, which are important about signs, symptoms, what to look out for, and then you can just go ahead and walk around. There's a patient who does some poems as well. So I'm going to network. Yeah. So I'm going to network his poems. I've invited him to come to stand with them. He's a laryngectomy, so it would be really good for patients to see. We don't invite thyroids for this. We think thyroids should probably have their own, just because with head and neck cancer, you know, it can be a bit daunting. A thyroid lady has been to one point, was a little bit daunting. She got really upset. And left, so we decided to leave thyroid out from health and wellbeing and maybe create one with the Christie, because we go there for a lot of treatment, and the thyroid MDT there, so kind of bring them together. So that is basically the personalised cancer care and what we do in the background, and what we do for patients really, that they all get that support from the day doc. So if you ever need anything, or holistic needs assessment, or a patient is telling you they've got worries or concerns, or because some concerns can come up after surgery as well, what that wasn't there at diagnosis. So we do say to them, you can always put your hand up and go, I've got a worrying concern, just come up and we can do one then. Any questions?
Oh, that's perfect.
Did you know about them? No? So it's really good for you to know that we do have that in place. So I've spoke a little bit, so Chloe's got to give me a little rest. Oh,
You want me to share these, Chloe?
Yeah, so just the SBTs. So we've done a bit of work about SBTs following the level
With Anna?
with Anna.
well, you did all the work.
So we've now come up with a poster that's going to be put at the back of every patient's bedside post-labby. It's everybody's responsibility though, just because I believe some of the nurses on the ward can't access appointments. We can and you guys can, so we're going to have it as a team effort. So that'll be laminated at the back of the bed. If we know the swallow test date, we're just going to put the date on, and it's just to make sure that we remove the SBT prior to going down to the swallow. We're finding that, and after a lot of research and looking into patients' notes, that patients are going down still with SBT in place.
We've actually audited that in the last 6 months. We had to treat them.
Was it free? I can't remember how many, and with their free incidents.
6 months. So that was 6 months.
Yeah.
I remember the numbers in the top of my head now, but I think it's roughly around 20 patients.
It's quite hard.
So it does delay discharging, you have to go down for another swallow. It can be quite distressing sometimes to patients because they look forward to, I'm going to go for the swallow test, I might be able to eat drink soon. It's something exciting for them after such a long stay on the ward. So we just want to make sure things are put in place and definitely.
So will be this built up as soon as they are out of the surgery? Will that be like a?
It'll be more fun to get onto the ward.
Yeah,
Because,
so
okay.
Yeah.
So who will be doing this? Because I guess you need to check the up notes to make sure that they do have one, because some of them don't have one as well.
Yeah, so essentially it's called a test date. Once we get a date, once we book it and we get a date,
yeah,
then we just get a date on it. If they have an SBT,
And you check at
Yeah.
time. Okay,
Yeah.
fine.
But it's more of
because
a,
some don't have SBT, do they? So you need to make, you can't just put it on every larynx.
Yeah, exactly.
So it's like we say, it's like all our responsibility. If we know we're doing
Just make
ward
sure.
round, or you know that
We're gonna go for
Mr.
a
Bloggs
have one.
is coming back from theatre, it gets to the ward, don't bother on
Yeah.
HDU. So when they're on the ward, and if you do ward round and you do it, you go, oh, he's got an SBT in, he's got a sign, I'll just go and get one. There is 10 of them, and I've laminated them so they can be reused. But do you know where the nursing stations on ETC? Have you seen that little plastic file thing on the right at the back?
yeah, I think I know.
There's tracking information, they're in there, so if you could just go and get one and stick it up. Doesn't have to mean you've got the date,
what you know,
but then you know they've got that in. So when we're doing ward round, it's that glance, oh yeah, they've got an SBT, why and what, should we have a look and see when the swallow date is? And then any of us, if I'm there, I'll put it, just write it on. And if you're on ward round and you've checked and you know it's on the 30th of June, write the date and the time. The time's really kind of important because a lot of them, did you find that a lot of them were morning ones that went down?
I didn't really specifically look into that, but I think knowing, because I was knowing one of the patients, it was happened that they went down before the team got to the ward, so
Yeah.
so it's something that happened before because of the point of action.
So I think after all the conversations we had, Hive is great, yeah, but we can't put an alert on at the moment today. Like they've got it on Monday, it's Monday morning, you take the SBT out. So we wanted a visual thing for everyone to see when
I think
you're
our next
doing
step is
water.
to try to integrate it, but until then, we've got the.
Yeah.
I'll do that email today.
And also, I think it's been sort of agreed of Ms Penny that me and Mel, when we talk, have removed them as well. Just because I know you guys get busy, maybe in A&E, maybe in theatre or whatever. We're there on the morning as well, so we could always get out if needed.
We were saying what would we know when it's busy, it can be really busy. If we've got 20 patients or before now we've had like 7 laryngectomies in at one. If we're on ward round with you and we know it needs to be, at least we take that, we'll stay, we'll take it out, you guys can carry on. And then if we have trouble, we know you're kind of still around. So yeah, so if you have got any, do please grab us and help us learn. I mean, we have seen loads we take out, but and also do so. Yeah, support us in getting confident with taking these out. And we know there's going to be some that we just can't get. You know, we'll try. You're going to try.
Yeah, of course. Yeah, we're learning.
Yeah,
We want to learn everything.
Yeah.
So everything.
So definitely. So if you know there is and we're around, just come and grab us and let us either do it or watch for you or assist, get in there. And I think that will just help.
Yeah, that's quite nice when it comes out.
Does it? I'll take your word for it.
I think it's also part of my job as well as Mel's is we do a lot of education with the nursing staff as well. And we were finding that NGs were placed back in after they come back from the swallow. One reason it's really important is because some patients need a lot of pain relief, need other medications, and the report might not come until the next day, or there is a leak and they know why now. So we just want to make sure that the nursing staff also know we need an MD straight in and come back as soon as possible. It's just another little checklist for the nurses as well.
It's more for medication as well, wasn't it? We had a patient recently needed calcium. Patients will refuse. Throw it back in, we think we've had it, took it out and we're breathing then, they don't like the tube. So yeah, the medication as well. And then chasing that report.
So is it the radiographer report and you guys people check it? Or is it just as soon as the radiographer says it's fine?
No, so we normally what we do is actually we physically look at the actual scan. But then sometimes, you know, it's 50-50 for a formal report.
Right.
That's the formal report is reported by the doctors, not the radiologists, or radiologists in the workplace.
Well, thank you. You can see it and you're like, it's fine.
Yeah.
And that's the majority of the time, isn't it?
Majority of the time it's other than not very obviously it looks fine, but then there are situations where it's 50-50 and then we just wait for that.
So hopefully, well, they'll be in place. We've started putting them up, haven't we?
Yeah.
I've had a few laryngectomy patients, so you'll see them.
Oh, you were saying about the stickers as well.
Oh yeah, so I'm trying to speak to SS Taylor about getting some alert stickers to go onto the NG as well. So you've got a visual, but you've also got something you can see. If like you were to walk, like take the patient down, you're like, oh, we've got an NG on, and that'll just say FBT in place, or just FBT, just a second alert. So when you take that out, the stickers go with them, so you know you're bringing the FBT. It's just a bit more complicated because it has to be designed by SS Taylor. So I am on it, and it should be hopefully sorted in the next few weeks. But the other part of my job, as an old stairway specialist, alongside the girls, there's a lot of teaching with the patients, the families, nursing staff, doctors. I also train some of the consultants on the medical side, A&E, when they want a bit of support. So I am here if you feel like a patient needs a bit of understanding of the tube we've got, or whether they've been admitted to A&E and you feel like we just need a bit of more of an understanding of humidification, if it's coming with chest infections all the time, or you think a different tube might be better, I can also do tube changes. I support the AM1 and 2 block for your ENT patients. So trying to discharge them home and make sure they're home safely, make sure they're trained and their pathway is good as well. Just because they're not on the ENT ward, they sort of get the nursing staff down there don't have the understanding that they do on ENT surgery, so I support them down there as well. But I have noticed, and you've noticed over the past few months, is patients coming out of theatre or coming in and having an emergency trachea, is there are a few things that are being missed across the board, so critical care nursing staff, ENT, the medic, is humidification for these patients and nebulizers are getting prescribed. So I was just kind of hoping going forward we can come up with a bit of a better plan for these patients. So whether when they come out of theatre, because I'm going to do a checklist, which I learned about up in theatre yesterday, whether maybe we could add something on the end of that to say documentation completed, humidification prescribed, but also maybe come up with a good plan of when you go and see the patient, if they're not using humidification aid like a protector or a HME, to try and enforce that as well, especially on critical care when they come off their oxygen or on AM12. Just to protect the patient, stop them with sick secretions and more problems, because it is quite a common thing that we're coming across.
Yeah.
Especially when they're coming through A&E or coming out of HDU. And like I said, it's a global thing. I've spoke to critical care doctors about it, we spoke to the critical care nurses, A&E, so I think it's just all of us together, just need to make sure things are put in place.
Yeah. I was going to say, oh yeah, and on discharge, always make sure CTOs, any airways, always put nebulizers on. Because there has been a few missed. Not recently, but in the past. So they always just have to have it. And then for us to get them through the GP, we then have to phone the GP, then email them before they even prescribe them. So, yeah, it's just a bit of a pain in the bum if they're not prescribed. We have to do a lot of phoning and emailing. So yeah, that's it really. Any questions on anything to do with what Chloe said, or Chloe, or her role?
I don't cover the peds side. I know there's a few transitional patients coming through, but if a paediatric chief does turn up, me and the paediatric tracking nurse need to be contacted at the moment. And so now there's been a few spots to learn.
I have a question, please, Mel. About the patients you see in clinic with us when we are breaking down news, discussing surgery, resection, injecting or dissection, anything which is quite new to the patient. Do you normally just have a chat with them about progressively what's going to happen, or do you have online information to provide, or getting them in touch with previous patients which have been waiting on? What is the best thing you would be helping with these types of patients, especially if they are in the shock stage?
100, yeah. So they'll always get the diagnosis on a Thursday with us. However, we will always bring them back. Yeah. So, and I do that with speech and language therapists. So if it was a laryngectomy, they'll get a bit of information, because you've got to give them something on diagnosis. You can't let them walk away thinking they're going to have a hole in the neck and they're not going to be able to speak, ever eat or drink. And you think, oh, what the patient goes through, like, I'm going to have this forever, like, I'm not going to be able to eat, speak. So Fran will always give them an information leaflet about communication and laryngectomy surgery, and she'll always go through a little bit of information. But we know they do not take that information in. They've just been told. They're losing the voice box and the whole anatomy's changing. 100%.
Especially with the injecting the
100%.
Bring them back actually.
Yeah, my plan. So we always bring them back if they're a Manchester patient. If they're from North Manchester, Bolton, Wigan, they tend to do a little bit of their training there. But if they're having a laryngectomy here, me, Fran, or Olivia, or one of the speech language therapists, we'll always bring them back. That's where we'll do an hour and a half, laryngectomy information and education. And they'll always have a family member with them. So we'll get the pictures out and everything, and we'll tell them, this is your laryngectomy now, this is after, and they can see. We get them to look at a speaking valve, so we get them to touch it, they can clean it, we give them a laryngectomy tube, we tell them about humidification before surgery. So they have all this education, so about nebulizers, they get told they're going to be nailed by mouth for a minimum 10 to 14 days. We tell them about the swallow test. So we give them all that information, and we offer, if you'd like to meet a patient, if you want to meet a patient, we have a list of patients who we know we can contact who are available, and we always try and get the patients who have the kind of same operation, if they've used an ALT or a PEC or a total laryngectomy, and round about the same age. We always try and figure it out. So we do have quite a lot of patients that. Yes, massive. We've got we have two patients very similar age, and the gentleman who speaks has a hands free as well now, whilst has a button. We can do it on Teams. If the person who's coming to meet the patient can't come, but then the patient will always be with us in the room and we'll always facilitate it. We never let a patient meet a patient on their own either. And we also ask, is there any questions that you do not want to be asked? Would there be anything that would make you feel uncomfortable? Because we need to make sure it's done safely. But a lot of times it's not. And then there's one patient whose wife will always offer to speak to the other person's relative. If you've got a relative, a wife, husband, partner, a daughter, if they want some support on how it felt for them, because we have to remember it affects everybody, the cancer diagnosis and surgery. And then, so the family members will always speak to another family member and go, well, how did you feel the day of the surgery? When you first seen him, how was it? What was it like when they came home? Did you have to get anything prepared? Did they need any special food, clothing, stuff like that? So it's really, so yeah, we offer that. And these are the things that, again, are happening in the background. So we normally do that on it could be a Monday, Tuesday or a Wednesday. And it happens in Peter Mountain, the salt room, in our little hub room. Anyone, not just laryngectomies, laryngectomies, eyes, we always offer, especially if you're having a prosthetic. I've got a young gentleman coming in soon, and we've done the same for him. He came, had his diagnosis. I've seen him again on Thursday, and I've offered him if he'd like to meet anybody between now and when he has a surgery, but he said no. But we always offer. But anything, and even if you want to see a picture, I've got patients that have consented for me to show them pictures. So they email me over, and I've got pictures that I can show the patient. So I get up on the email and go, this is a guy who's had a prosthetic, and you like, that's him now. So if you ever in clinic and you have anyone, ask me, I've got the pictures there.
I definitely think that my own experience with Lyme, it makes a huge difference between patients. I think it's such a scary process coming out of theatre at 7 o'clock at night, going to HDU, understanding you've got lines in, monitors on the flat.
And they'll have a tracheostomy in for 12 hours, we tell them that.
And then like the process of, you'll stay there for so long, ENT will do the day after, we'll change the tube, we'll send you down to the ward, we'll do this, we'll do that. There'll be a period of time where for 10 days you might feel lull and you're not doing much and you're just doing education. And then you get the patients who are really good and understand that and kind of get the gist of it, don't they? And then they understand that I've got a few days not doing anything. And they've not had that education, they can find it quite stressful and they don't want to see the Larry. They don't want to engage in teaching, and it's quite hard to get them around that corner and say, we need to.
Do you remember, sorry, we had a patient who point that, I think from, I don't know if it was North, we had 2 of them North, 1 from here, didn't want any pre-education, didn't want to meet anyone. And I've said from that day out always, it was really hard to get them engaging after. So I've said from that day, anyone who's going for major surgery, if they're having a laryngectomy, definitely, I think you've got to come for the pre-education. It's part and parcel of you signing your consent form, because you can't sign a consent form, it's what's going, you sign it for what comes with that. Because it was really, really difficult to get them up and moving and to get them doing things. So I think it comes with part and parcel now. If you have a laryngectomy, you must come back to this meeting to speak to us with your family member, and it's like, oh no, don't want to know, don't want to know. Unfortunately, you're gonna have, you have to, and we kind of encourage you. So it might take a little bit more time, and we might have to do it in stages, the pre-education, but we will always do it now. And it's always done with speech and language therapists.
Good, great. I discussed it yesterday, because you see the patients pre and post different surgeries, like the open filtration, recovery, injectomy, neck dissection, with several complications. Which patients do you think we have the worst private line after surgery? Which are the ones who are, you will have this, and I know that you don't have numbers, but at least, are there direct patients, direct fed, or the laryngectomies?
I'd say laryngectomies, no. I think they really.
Or are they equal? Because this is something we can look into.
I was thinking of it this way. You asked me yesterday, and I think recently the ones that have been struggling is the
oral therapy, the one that have really bad post-therapy that comes forward on a regular time, and probably don't have the
Yeah, just good, yeah, they're the ones that really struggle.
Even the ones we see in clinic, 3-6 months down the line, they're still struggling.
And it is a lot with the post-treatment, it's not the actual laryngectomy in the end, it's actually what's come with that, the rig, the dry mouth, the redness, the wound breakdown, they won't go out. They won't go out the house.
Even after the house and the hospital,
They'll go to the hospital, but you find that, and a lot of, when we find the information out, it's because of the relatives coming back, they won't go out, they won't mow back, they won't walk in and go, right, you need to start, like, when we walk around the garden, encourage you, and that's what the health and wellbeing events are about. It's about bringing that quality of life back to patients who, you've gone through this cancer journey, you've had absolutely traumatic, like, really major surgery, really intense radio chemotherapy, to live your quality of life the best you can, and that's what the health and wellbeing is about supporting them to get them to go, but actually, yeah, I can. A lot of patients that have the eyes and noses and prosthetics, they really struggle as well. I'd say in that period of waiting for the prosthesis. Some patients don't even have them, but what we've noticed recently is we've got a couple of patients where it's the decrusting. So they're coming back to that quality of life where they're waiting for the prosthetic, and why things are settling down, and the radiotherapy makes it more angry. It's all to do with that. So they won't go out. And we've got a couple of patients even now with the prosthetics that still I've had to get counselling for them, like 12 months down the line. I still get phone calls weekly of some patients, you know who I'm having to support because their anxiety levels are that high. Won't go out, won't socialise with friends because they think they look different, and you kind of get it. It's here, isn't it? It's not your eye anymore, or your nose has changed, or the way you smile. So that's why we do the wellbeing calls. We keep our door open for all our head and neck patients. We do the health and wellbeing events, the EHAs.
Rachel will bring them in as well, if they're really struggling at home. We've had a few
in our counselling room.
We'll bring like a few post-larries who are really struggling, or anybody else, but sit down and have a really good hour with them, talk through stuff, try and support them. If they don't like the look of it, we'll try and come up with things to disguise it, which makes it a bit nicer for them. Yeah.
Great. And about the complex discharge patients, is there anything we can help with prior to reaching that point of decision, just to help you in the process out of the hospital? Is there something we can discuss?
You are a lot to do with complex discharge, don't you?
What do you think? So, because we are stuck sometimes with patients for 2 to 3 weeks.
Is that more complex in like fistulas and things like that, or complex in patients, complex in general, physically?
Patients,
if it's socially, yeah.
Socially, yeah. Something.
I think there's not much you can help with in general. It's just having an understanding that what complex discharge needs to try and get the ball rolling. Their paperwork is so in depth, and the words need to be perfect on paper for them to even get it through to the CCG. And that's why it all gets accepted. So they do a document, gets sent to CCG, they accept it, and then they get all the funding to get home. So a lot of it is being in contact with a little bit of complex discharge as well, and they the paperwork they're doing, they have like a cut off to get it done. So I think it's just support on that side.
So there's nothing from our side to do?
No, not really.
It's not paperwork. As soon as we get the paperwork, or as soon as you know there's going to be a complex issue, let's get referred ASAP, let's get the paperwork. And a lot of it's communication with complex discharge team. You can just stay with them and just say, I've got this gentleman, can you come and see them, we'll put a referral through.
The best thing
or speak to us and ask us to speak to them.
The best thing is the complex discharge team at the moment, only 2 nurses will cover our head and neck patients because of their airways or complex side of it, and they understand what needs to be put in place, so they will just give you a bulk paperwork and when it needs to be done. And as soon as it's done, it's normally for annual meetings to crack on and get them. To be honest, we don't do much after the paperwork's done, it's their job. There's nothing much of a doctor you could do to help.
And I think we do quite well with that, you know, I feel like what if complex discharge say we've got either fast track paperwork or we bring it up and you get it done. We get it the next day, so I don't think you do quite well on that.
Oh, the ones on the AM1 and 2, the more complex airway ones, it's just having a very strict process of this patient can or cannot be decannulated. That makes a big difference as well. But that'll just be scoping every week or so, just to double check if the vocal cords are getting any better. So that's the biggest question I get asked. Can we decannulate this? If we can, I can get them to an easier way. Because it's the trachea or the airway that causes the problems.
Do you have any videos on your ankle liver patients? Do you need any?
Videos for any of the surgical training. We direct them to, so if it's airways, laryngectomy, you can have the national, NTSP. Yeah, and there's lots of, so I know there's lots on YouTube as well, which are accessible for patients. So it's about, there's a gentleman there about speaking with a laryngectomy, and he'll talk about, and you can hear him speaking. And there's one about feeding, so that we can direct them to that if they wanted to. But we personally don't. Me and Anna have spoke about this before COVID even came. Say we want to do educational videos, even to the point of an NG tube. This is an instruction. We've spoke to Sharon and everyone about legally how to do it. We have a YouTube page, and we need to figure out what's going to be monitored and who's going to monitor it to be able to get the videos uploaded. If you wait as well for medical illustration to do, you can be waiting forever and a day. We did a video on my 40th birthday for Health and Wellbeing event, and we got it about 9 months ago. I'm 43 this year. And I'm not even joking. I came in on my 40th to do it. And it was all So waiting for medical illustration is half the staff have left now. That was on the video. So it was all to do with the Health and Wellbeing event. We wanted to support patients during COVID, so they could have a link, click on it, and we would Sarge's on the video with me and Anna. So we were doing it kind of that way. COVID had finished by the time we got them. Well, not finished, but things had gone back to a little bit of normality. So I've asked if we can use private or we can use our phones. So we want to do educational videos for patients.
That would be great.
100%. And they've said now you'll be able to use Hive and things.
Yeah.
So if you want to be involved in doing some of them, like have an NG tube put in your nose.
What is the problem with that? Is it the legislation or the
It's all to do with comms, it's all to do with the legal side of things, and who's going to monitor it. So if you're getting comments.
You can do it on the MFD,
Yes.
We can take it only now.
I might ask Alison.
Southampton and Cumbria have one where you log in and you get given a password to log in, and they have an e-learning for patients, and you just go through e-learning.
That'd be really good.
In Liverpool, actually, they've got Liverpool Head and Neck, their own website. So they built on their own website, and they've got a YouTube channel, and there they've got not just patient education videos, they've also got surgery recorded with the surgical steps.
That would be so good.
But I think the setup there is that they've got a dedicated team working on the website, which probably I assume that they're monitoring, uploading and the website.
Yeah.
So it needs a lot of work.
I think we've been speaking
also
with Prof about it.
That'd be good.
That'd be good.
Get something like this Manchester the next time.
So what we need to
Check
do.
the website. Check the.
I'm gonna
the Liverpool website.
That's what I'm gonna do. I'm gonna contact Liverpool CNSs as well, But I think then also having a team together to us all, that's probably another meeting where we could all come together and say, how to create, I know Professor Holler is looking into getting something for prehab, like an app or something, but we could get a website like instead and have prehab care videos, whole stuff, and beyond. I'll have a look at the Liverpool one, that's really, yeah. I think that's a good thing.
At the moment,
I think that'd be a really good topic to get stuck
For all of us, especially the patients will be trained quickly, they will be discharged quickly. This will be just like motivating them.
And it's there.
Yeah.
You can go back constantly on it. So yeah, I think it is things that get spoke about, but I think we should look at how can we do this? What do we need to put in place to do it? Everything comes down to cost, unfortunately, and money. So it is out there. Do we have to do a few more things for charity to put in the pot to build these things?
I think so.
Cake bake sales, you know, who's gonna do a 10K? Who's doing a marathon? Because I'm certainly not. I'll have a dance off. Yeah. I was thinking, do you know what I was thinking about this? Saying, you know, the social of having a charity night in there and doing a bit of bingo, and doing some stuff. So yeah, so I think we should all come together because it will come down to funds and money and who's going to fund this and who's going to fund the people to create the website and man it and like what they have at Liverpool. So we'll get in touch with you.
I think we started with the small bit, which is consenting and videos.
Yeah.
We have the material.
100%, yeah.
We build on the website, but initially,
Let's start.
just start with legality first. It is just like consenting conditions to agree to be recorded.
Yeah.
And put it on our MSD drive. And then later on, we will think of a website or something.
And we've got things there ready.
We have something ready. So
Yeah.
who to speak to first with this medical
It
legal?
has to be medical, legal medical section, which are really cool that are just doing.
Yeah.
And we will be more than happy to help with recording.
Yeah.
We can do tube changes, traffic training, swallow training.
Yeah. And I know speech and language are really keen because we have spoke about it loads in the past, but then unfortunately we get busy or nothing happens. So I think if we get a dedicated team to come together where we have different roles and stuff, then we can.
At the minute, the only thing that's available is, have you ever heard of Atos?
Oh yeah.
It's a company that we refer all our airways into, and Atos do have a lot of information for patients pre-Larry and post-Larry. And it's just fact sheets, isn't it?
Fact sheets, yeah.
It's quite,
They do
really
stuff
good.
on, if you're a new laryngectomy, you know, what do you need to do to prepare to go on holiday? They'll give you, there's a webinar on that, or the change in weather. They do a webinar and how it will make you feel with your laryngectomy or airway. When the weather changes, the way you breathe and your secretions change. So they do all stuff like that on there. It's really good. So we can, yeah.
If we're doing our own thing, seeing us or yourself or the patient will just like be very confident that everything is being made. It's not like sometimes they are listening but they're not.
Yeah.
I agree.
So, no, I don't understand anything that needs to mind.
Yeah, and you do get that, don't you? Because it's like, but if it's there, you can keep going through it with the family members. Yeah, I agree.
So let's start. Yeah.
Right.
Just send that first email, and things will roll down. So
Yeah.
let's start with the person to talk to first.
Yeah. Well, we'll do that. That was today. So.
And yeah, put us on the email.
Yeah. Get it all.
We'll see how things, because we are thinking that honestly.
I think it's. I'm gonna go on to Liverpool's and have a look at theirs, and we'll email.
From your side, it will be the training for patients. From our side, it will be surgeries and stuff.
Yeah.
But at least we have something with.
Yeah.
Maintaining.
Cool, though,
Yes.
when we talk to patients.
Yeah, 100%.
And we'll leave this website or post it into the.
Check. I've sent you the link for the.
Oh, have you?
Liverpool.
Right.
Yeah.
There,
We've got like very simple
Yeah.
videos, you know, like for the TNO clinic we were doing. You know, like information really good.
Exactly, yeah, we
You
can
know,
do.
what is the TNO code, you know, type of,
Yeah.
it's quite useful, we can apply it to lots of,
I think it is definitely the way of moving forward now,
Yeah.
because
and then the
we
thing
have
is
to move with the
and I
times.
guess with Hive, you can use the time as well.
Someone else has said that,
Yeah,
so I need to get in touch with this high person. Get in touch with, I'm not coming to these training sessions, give me too much work to do. Yeah, so we'll move forward. I think we're just going to finish off quickly with, I think some of you knew a while ago, myself, Alina, Amy and Professor Homer, we were doing some work on the tonsillectomies and tongue-based mucectomies about their pain management after surgery. And it's always hit and miss. At the moment, we found all this data and Alina presented this at a conference, and I think at Newcastle, I think what we found is patients go home with a mix of analgesics. Some just go with pain paracetamol, some go with morphine, paracetamol, codeine. In Newcastle, I think they use pregabalin. So it's about, we're up to the stage now where we've got all this evidence and now we want to create a discharge pathway. So every patient goes home on the same discharge plan. So from Amy's point of view, it would be, we probably send them home with some nutritional packs just in case they struggle to swallow a couple of days post-op. The same medication. So it's gone to the consultants at the moment and it's gone to the anaesthetist, and we're just arranging another meeting to get it all together. So it's just so you're aware, again, it's something that we do in the background to do with changing patients' experience pathway. I found when we do our wellbeing calls on discharge with the mucectomy, some would be fine, but the majority, day 3 to day 5, would struggle with swallowing, eating, and we found that a lot of patients would bounce back into hospital needing an NG tube because the pain wasn't managed. If the pain's managed, we feel like they would be able to even get the, is it Meriton that Amy gives them? So if they had that just for a couple of days, get the pain managed, at least they're still getting some nutrition and it avoids them bouncing back into hospital. So it's just something else, that's why I had you here, that I thought, well, we'll bring it up just so you know. If you have any, if anyone wants to come on and have an input with the next phase of this, which is, it'll be like an algorithm, like they've had this, what they go on with, TTOs, and then the dietitian. I think Amy would like to see them all, so sometimes we're doing day case, aren't we? So if Amy sees them, she'll give them a pack and just say, this is what you get, I'll give you a ring in a couple of days. So it's just so we're all aware and we're all kind of go on the same pathway. It is hit and miss at the moment. And that's it.
Well, thank you so much for this amazing talk.
Yeah, I've got a list of things to go back and do. Thanks. I don't mind. But no, it's been good. Is there anything that you want to like speak to us about, or anything that you think we can